Sir, can we start the section?
I think madam has not joined. I think we'll wait for another few more minutes.
Okay. So Sam sir just joined.
Yeah, I think we can start.
Okay,
Anand,
okay.
Anand will introduce.
Yeah. So good evening all. Today our topic of presentation is obstructive uropathy. We are presenting a case of posterior urethral valve with the urinoma. So as you all know, this is a devastating disease which can occur in the newborn period, particularly as a obstructive uropathy in boys. And the severity is wide and it's varied in the sense that in extreme cases, it can be incompatible to life. And in milder cases, it can present as just later in life with urinary incontinence and other urinary symptoms. And the management is also, it's a challenging. Management is challenging. Clinically is also challenging, and it can, which includes a surgical resection of the urethral valve, and the follow-up of these babies is required during early infancy up to adulthood. So mainly to avoid the progressive bladder dysfunction and for preventing the onset of a chronic renal disease. Even though we can say that it is just a membranous fold, it can produce a severe end-stage renal disease in the newborn period itself. So, so addressing this problem, we have taken this topic, and today we have two experts with us, Professor Sam Barkey sir, who is the professor of pediatric surgery, Government Medical College Trivandrum. Welcome sir to this Zoom meeting, as well as Dr. Ratika, who is the associate professor in pediatric nephrology department, Government Medical College Trivandrum. So both the experts, I am welcoming both the experts to this meeting. And over to Amal. Amal is our second year DM newborn neonatal resident. So over to Amal for the presentation.
Thank you, sir. Good evening, everyone. I am going to present a topic of obstructive neuropathy, a case of PUV with the urinoma. So these are our experts already introduced by our sir. So going to the topic proper. So this was a case of 23-year-old preemie with no comorbidities, with a gestational age of 35 weeks 4 days, delivered a male baby born via LSCS due to orgamnios on January 3rd, 2024. The birth weight was 2.46 kg, which was appropriate for gestational age. Antenatal scan done on 28 November 2023 at 30 weeks of gestation. The right kidney APD was 13 mm, left kidney APD was 10.5 mm, and the fetal bladder showed keyhole sign. The AFI was 11.7 centimeter at that time. The repeat scan at 21st December 2023 showed an AFI of 7.8 centimeter. The delivery room management, the baby had a weak cry at birth with meconium stained amniotic fluid was also present. The baby required resuscitation at delivery room, intubated in labor room. The Apgar at 1 minute was 5 and the Apgar at 5 minutes was 8. In NICU, the baby was connected. The baby was shifted to NICU, connected to SIMD mode with minimal settings. Umbilical vein catheterization was put. Initial investigation sent. The initial chest X-ray was suggestive of low lung volume, and we were suspecting of pulmonary hypoplasia. And the bedside echo showed severe pulmonary artery hypertension, for which we started sildenafil also. Injection Pipso was also started, considering the clinical condition of the child. The initial VBG's pH was 6.988, carbon dioxide 69.3, bicarb 16.6, lactate was not available. And the VBG was suggestive of severe metabolic with respiratory acidosis. Mixed acidosis was the picture. And CBC hemoglobin was 15.5, platelet 1.94 lakhs, and CRP 0.65. The urea creatinine At the postnatal day, first was 20 by 1.4. The creatinine was 1.4. The pediatric surgery consultation was done in view of antenatally detected posterior urethral wall. And they catheterized and drained 10 ml urine, and that urine sample was sent for culture also. They also advised USG KUB. The USG KUB on postnatal day 1 showed bilateral perinephric collections. On right kidney, 3 into 2 centimeter hyperechoic area near upper pole, and lower calyceal pelvis show mild dilation. In left kidney, there is 3.6 into 2.6 centimeter exophytic from paranephric collection was also there, and there was a dilated posterior urethra. And bladder wall thickening with the trabeculations was also seen. So this was done by our radiology madam, and the madam was kind enough to show by drawing us the same image and make us understand how it looks like. You can see 2 kidneys in this diagram. 2 kidneys.
ఏమైందంట?
Please kindly mute others.
Dr. Ligita, can you please mute? So in this picture, you can see 2 kidneys, right kidney and the left kidney. In the right kidney, here you can see one cyst. There is one cyst in the upper pole, and there is a collection in the interpolar region, anterior interpolar region. So this is how the ultrasound look like. So there is a cyst in the kidney as well as a perinephric anterior interpore collection also there. And this was finally revealed as urinoma. This was a urinomic collection. This is a collection of urine seen in the interpolar region. And this is a cystic dysplasia that occurred kidney due to the posterior urethral wall. Due to the back pressure of the urine, the kidney got damaged and the nephron development become jeopardous. And finally, cystic changes occurred. So that's what the cystic change. Left kidney also you can see one cyst because posterior urethral wall affects both kidneys. So you can see cystic changes in both kidneys. So this is what we saw in postnatal ultrasound KUB. So this is that live photo of the postnatal ultrasound KUB on the first day. So this is the perinephric urinoma, the large collection you saw. We can see in the interpolar region extending as an exophytic collection around the kidney. This is urinoma. This is how that ultrasound picture looked like. On postnatal day 2, the baby had required increased effort to requirement and worsening distress. The baby is already on ventilator, and the baby required more oxygen. The chest X-ray was suggestive of left-sided pneumothorax, and left ICD was put by pediatric surgeon. The urine output was normal at that time. So we also got a left-sided pneumothorax. We are also suspecting a case of pulmonary hypoplasia, and maybe that contributed to that pneumothorax also. And meconium aspiration was also there at delivery. So this was the image of the X-ray where you can see the ICD in the left side. This is a resolved case of pneumothorax. Pneumothorax already resolved. This is the ICD. You can see the ICD in the left side of the chest. So what happened in postnatal day 3 is the FiO2 requirement still increased and chest X-ray still showing low volume lungs. So we gave surfactant was given on postnatal day 3, and the serum creatinine value on postnatal day 3 was 1.6, and the urine output was still normal. On postnatal day 4, the polyuria started with the worsening creatinine. So this was the onset of polyuria in this patient. The serum creatinine now became 2.1. And the blood investigations showed thrombocytopenia, platelet of 32,000, CRP of 12.6 milligram per deciliter, and we graded the antibiotic to meropenem, the renal dose. And VBG showed mild metabolic acidosis. The postnatal day 5 also polyuria persisted, and the hypokalemia and hypophosphatemia was diagnosed and correction started. Pediatric nephrology consultation was also sent on the same day, and they advised to add nodosis and to continue the present line of management in view of persisting metabolic acidosis. Postnatal day 6. Postnatal day 6, there was the first spike of fever. Vancomycin added with the renal dose. blood and urine culture admission. Postnatal day 6, the first spike of fever was in, and we added vancomycin. We were suspecting of an infected abscess, urinoma may got infected. In view of that, we added vancomycin. And blood and urine culture sent at the admission was sterile. So now we are thinking of an infected urinoma. On postnatal day 9, in view of pallor and high FiO2 requirement, PRV packed red cell transfusion was also given for the baby. Postnatal day 10, Ciplox linezolid was added in view of persisting fever. On postnatal day 16, the baby was extubated. The CT abdomen and thorax was done on postnatal day 18, which showed a 2.4 into 1.6 centimeter partially exophytic thin-walled cyst with mural calcification in anterior interpole of region of the left kidney. The right kidney also showed the similar pattern only. And also there was a right inguinal scrotal hernia. No lung parenchymal abnormality except for segmental atelectasis in right lung middle lobe was noted. On postnatal day 19, new onset fever spike was still there. So we added injection digicide. On postnatal day 20, USG guided aspiration was done in right kidney by interventional radiologist. Because due to the persisting fever, we were suspecting the infected urinoma and we have to diagnose because blood culture and urine culture was not suggestive of any infection. So we planned to remove the cyst and look what is causing the infection. From right renal cyst, 12 ml straw-colored urine was what we obtained during the USG guided aspiration. But the attempted aspiration from upper, no aspiration was obtained. I already told there was two collections
please
there.
mute. Others, please mute.
Others,
Can requesting all to mute, please.
okay. So coming to the early picture, you can see one cyst in the right kidney as well as the perinephric, that urinoma also you can see. The interventional radiologist actually aspirated from this side, this urinoma, and what he got was the urine only. Also tried aspiration in this cystic area, but he didn't find any collections. He didn't aspirate any content from the cystic area, only blood was there. So it was suspected as a case of localized hematoma only. So he was able to drain from here, this urine portion, not able to drain from the cyst. So this is cystic kidney only, and this is urinoma. The renal aspirate fluid, total cells was 54, RBCs 3 to 5, protein 154 milligram percentage, sugar was 61 milligram percentage, the creatinine was 6.4, and everything was suggestive of urine only. All the back tech, urine culture and sensitivity, CSF, renal aspiration fluid, everything came as sterile. And finally, MCU was done on postnatal day 32. It was suggestive of posterior urethral wall. And this was the image of the MCU. Here you can see the dilated posterior urethra during the voiding time, which is a classical feature of posterior urethral wall. And finally, cystoscopic fulguration plus right herniatomy with the right orchiopexy was done on 8th February 2024. That's yesterday. So basically, the case summary is baby of ANSIA, 35-weeker, diagnosed with the antenatally detected posterior urethral wall, delivered via LSCS with MSAF, required resuscitation at birth, and prolonged mechanical ventilation for suspected pulmonary hypoplasia. PPHN was managed with sildenafil. Surfactant was also received. Postnatal ultrasound KUB suggestive of PUV with urinoma and cystic changes in both kidneys. Fulguration was done on postnatal day 35. So this is a case of posterior urethral wall with cystic dysplasia with urinoma with the underlying pulmonary hypoplasia as a complication of the oligohydramnios. So this was basically our case, a posterior urethral wall seen in the newborn. Sir, can I go to the proper topic?
Yeah, I think we'll ask our nephrology and our pediatric surgery opinion. Then we move ahead with the topic presentation. So, Sam sir, hello.
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 Can you hear me? Can you hear me?
Yeah, sir. Yeah,
Ah,
yeah.
yes, sir. Yes, sir.
Yeah.
Sir, can you elaborate on the postnatal management in this scenario, sir? In this case, urinoma plus a posterior urethral valve, and what was the findings in the cystoscopy, sir?
Yeah, sure. So, posterior urethral valve along with urinoma is, I think, almost 3 to 5% of the children present with urinoma. It's supposed to be one of the pop-off mechanisms, prevents the uh, upper tract from back pressure changes. But in this child, already the child had dysplastic changes, plus urinoma and plus pulmonary hyperplasia. So initially the creatinine was raised high, but on bladder catheterization, I think the creatinine came down. And once the child was stabilized, we could take in the child for a cystoscopy and ablation. So when we did the cystoscopy, it was a type 1 valve. A type 1 valve is the most common type of valve which is obstructing. So we could fulgurate the valve. We did that in the 5 o'clock, 7 o'clock, and 12 o'clock position, relieving the obstruction. The child also had a associated hernia and orchiopexy, which we repaired. So, coming to the what would you like to know about the management, or shall I shed the light on after the complete presentation?
Yes, sir. After the presentation, we can.
Hello.
Yes, sir. Yes, sir. After the presentation, you can share, sir. Share the management part.
Okay. Okay. So this okay. Then carry on.
Sir, one thing I have to tell is that this section will end in 10 minutes. So all audience, please rejoin the meeting with the next password, and I will provide after this section the Telegram group. This section will end in 10 minutes.
Okay,
So
carry on. Amal, proceed.
Okay. So coming to the proper topic, posterior urethral valve in newborn. Morgagni described the posterior urethral valve first in 1769, and it was confirmed by Langenbeck in 1802. Both were based on postmortem dissection. The first endoscopic diagnosis of a urethral obstruction was done by Young, and he termed it as posterior urethral valve. As Sir already said, posterior urethral valve are obstructing membranous folds within the lumen of the posterior urethra. It is the most common etiology of urinary tract obstruction in the newborn. Epidemiology. It occurs in 1 in 4,000 to 8,000 pregnancies. It is the most common cause of chronic renal disease due to urinary tract obstruction in children. Classification. It was proposed by Young in 1990 based upon autopsies of a case series of posterior urethral valve. So according to the Young's classification, there are 3 types. Type 1, which is the most common type, type 2, and type 3. So this was the actual image of the Young's classification in 1990. Type 1, type 2, type 3. The types are classified based on the location of the membrane causing the obstruction as well as the type of the obstruction. In type 1, you can see somewhat the obstruction is lower. The membrane extends downwards and inferior and joined anteriorly to form the obstruction. In type 2, the obstruction is somewhat upward, the high direction. Type 3 is almost a diaphragmatic-like obstruction with a hole in the middle. But nowadays, it's been said that there are no 3 different types of classification. There is only one type, and that is type 1. Type 2 is only due to the dissection artifact, and type 3 is actually a type 1 with the catheter in situ. The catheter will cause a opening in the diaphragm, causing a hole. So actually there is only nowadays it's considered only there is type 1, type 2 and 3. Or one is dissection artifact and the other is the catheter in situ in a normal type 1. So this is a classification proposed in 1990 by N. Next, pathogenesis of posterior urethral wall. So there are different postulates telling about the pathogenesis. So it's an obstructing persistent urogenital membrane is a reason for PUV. Still the exact mechanism is not understood. So, but we can tell that the disruption of normal embryological development of the male urethra between weeks 9 and 14 is the reason for the development of posterior urethral wall. There will be an obstructing membranous fold within the lumen of posterior urethra. So clinical manifestations in the developed world, 1/3 to 1/2 of the posterior urethral wall are identified by the prenatal ultrasound. And the clinical features of newborns are respiratory distress due to lung hypoplasia, abdominal distension due to over-distended bladder or urinary ascites, difficulty with voiding, poor urinary stream, then straining or grunting while voiding. So these are the clinical features of posterior urethral walls in newborn. Then what are the relations with the posterior urethral wall and other consequences? CKD, renal and urological consequences associated with the posterior urethral wall are chronic kidney disease, vesico-ureteric reflux, and bladder dysfunction. So what's the relation between PUV and CKD? First thing is a renal dysplasia, which manifests as renal cyst, which is already seen in our case. There is 60% association of renal dysplasia with the prenatally diagnosed posterior urethral wall. Then acquired renal injury due to infection or ongoing issues with the poor bladder function will subsequently affect the already damaged kidney, leading to CKD. Then approximately 15 to 20% progress to end-stage renal disease. So actually the reason for renal dysplasia is what I have already told, the back pressure arising from the urine will disrupt the developing nephrons, causing the maldevelopment of the kidney, causing renal dysplasia, which manifests as renal cyst. Then what is the relation between PUV and vesico-ureteral reflex? 1/3 to 1/2 of patients with the posterior urethral wall will have vesico-ureteral reflex. And we know that it's a secondary VUR because the VUR is caused due to posterior urethral wall, so it's a secondary one. 1/3 will resolve with the relief of obstruction. Bilateral VUR is an independent risk factor for end-stage renal disease. So this is an image showing posterior urethral wall with the left vesico-ureteral reflex. So in this image, in the right-sided image, you can see the left-sided vesico-ureteral reflex also, along with the dilated posterior urethra. This is a case of PUV with the left VUR. Now, what's the relation between PUV and bladder dysfunction, which is also an important relation? You know that there will be a muscular hypertrophy of the bladder, thickened bladder wall or trabeculations and diverticula, overactive bladder, poorly compliant bladder with the high filling pressures. Bladder symptoms may even persist after relief of obstruction. So the main problem here is that the bladder has to pump against an obstruction. That will cause the muscular hypertrophy of the bladder. And the speciality of that bladder is that overactive bladder. So that bladder means even after accumulating a small amount of urine, the bladder begin to contract. So the babies will be having incontinence even after relief of obstruction. The pathology in the bladder will persist even after relief of obstruction. Means even after you treat a case of PUV, the pathogenesis in the bladder will persist. The bladder is still an overactive bladder. When it accumulates a small amount of urine, it begin to contract, causing urinary incontinence. So you have to treat bladder symptoms even after treating PUV. Now, urinoma. What is urinoma? Urinoma is an encapsulated accumulation of extravasated urine in the perirenal space or retroperitoneum. So, DDs of a cyst mass located between kidney and spine includes urinoma, lymphangioma, hemorrhagic neuroblastoma, mesenteric cyst, multicystic kidney disease, and polycystic kidney disease. Then, urinoma is seen in PUJ, PUV, etc. And one thing is that bilateral urinoma, you will get bilateral urinoma in PUV and unilateral urinoma in PUV obstruction as per the pathology. So this is another image showing perirenal urinoma. So as arrow points, you can see a perinephric urinary collection in the kidney. So that is perirenal urinoma. Now, what is the relation between PUV and urinoma? The incidence of urinoma associated with the posterior urethral wall is 1 to 9%, and it is a method of spontaneous decompression within the collecting system. Urinoma and urinary ascites, both of them are spontaneous decompression within the collecting system to protect the kidney from the end-stage renal disease, despite the significant mass effect on renal parenchyma. And it is actually a controversial topic also. As Sir said, when there is building up of pressure, this urinoma will act as a pop-off valve, relieving the pressure from relieving the kidney from the excess pressure due to the back pressure of the urine. So it's just like the ambu pop-off valve of the ambu bag. Just like pop-off valve relieve pressure in an ambu bag, this urinoma will act as a separate collection of urine, so that the renal parenchyma will be protected from the excess pressure developed within the kidney. The urinoma will protect the renal parenchyma from the excess pressure. So we can tell that urinoma is protective. But this is a controversial topic, because if you compare a kidney with the urinoma and a kidney without a urinoma, which kidney is good? Actually, we cannot tell, because a kidney with the urinoma is already, at least you can tell that the renal kidney is involved. A kidney with the urinoma means you can tell that the kidney is involved. But a kidney without a urinoma, you can tell that that kidney is not involved also. So when you say urinoma is protective, also you have to know what you are comparing with. A kidney without a urinoma and with the urinoma. With the urinoma means kidney is already involved. Without a urinoma, the kidney is also not involved. That's one thing you have to think about. So this is a controversial topic. Then associated anomalies with the posterior urethral valve are tracheal hypoplasia, patent ductus arteriosus, total anomalous pulmonary venous connection, mitral stenosis, imperforate anus. So how will you diagnose a case of posterior urethral valve? So you can prenatally diagnose as well as postnatally diagnose. Prenatal diagnosis is with the antenatal ultrasound, which show bilateral hydroureteronephrosis, distended and thickened bladder, oligamenous, then dilated posterior urethra displaying keyhole sign. You can also do fetal MRI, which shows the degree of ureteric obstruction and the degree of lung hypoplasia, also cystic changes in renal parenchyma. So this is the keyhole sign, where you can see the dilated posterior urethra and the dilated bladder, which is an antenatal ultrasound finding of the posterior urethral wall. So my section is going to end. Everyone, please rejoin the section with the password I am sending to the Telegram group now.
Amal, please send to Sam sir and Dr. Adhika also.
Okay.